Welcome to our very first rapid response podcast for Roper St. Francis Healthcare. My name is Patty Steele and I work in professional development, and I've been a critical care nurse for more than 25 years. I will be facilitating this podcast. Today, I will be introducing some of our rapid nurses to you. The first one who will be speaking is Liz. Liz Parker works downtown at Roper Hospital and has been a nurse for a little over 4 years, being a rapid response nurse for almost 2. A side note, Liz actually has been in the Army Reserves for 10 years, has had 3 deployments, and recently became a lieutenant. So thank you for your service, Liz. Our second speaker is Erin Weaver. Erin works at Mount Pleasant Hospital as a rapid nurse. She has been a nurse for over 20 years and a rapid nurse for more than 5. We have such experience here. Thank you, ladies, for being here. Another rapid nurse planned to be here and did all the work ahead of time for this, but was unable to participate. So we'll have to give him a shout out. Mike Benson. He has been a nurse for 10 plus years and a rapid nurse for more than 5 at St. Francis. So unfortunately, he had something come up and he was unable to be here, but thank you for your work on this efforts. So without further delay, let's jump into our first question. Liz, can you tell us the role and the purpose of a rapid response nurse?
It's a great question. And really, to sum it up, we are the liaison between the bedside nurse and the providers, and the bedside nurse and the patients. We're there to be an extra set of eyes. We're there to help you assess. We're there to help generating some orders. And we're also there to be educators for you. You know, there's always things that we come across in our nursing practice that maybe we haven't had experienced or have questions on. And so really we're just there to support you in your role as a nurse and help you be more confident in your role and to help support the patient and keep them from declining and get them on back on the path to wellness. You should contact Rapid for several reasons. The first is in an urgent emergent situation, get us on the line, get us to bedside. The second is you detect a decline in your patient and you want to be proactive and keep them from declining further and get them stabilized. And then another reason you would contact is IV access, although we strongly encourage you to really work on your own skills, hone those skills, and utilize your teammates before calling us for IV access. But we're there to help with that because we do understand that patients need antibiotics and lab draws and things like that. But do try to use your teammates before calling us for IV access. And finally, again, we're there to be educators. There are procedures that you might not have done that you don't feel confident with, disease pathophysiologies that you might want to walk through, or even talking about meds or why what's being done is being done. So we're there to support you. We're there to stabilize, but the primary role is there's a decline in the patient and we have to kind of keep that domino from tipping over and from the patient crumping and it being an emergent situation.
Yeah, that's awesome. Now, what do you think, and maybe you've had some situations that have happened like this, Liz, what would you like for all teammates to know before they contact you? Is there like assessment skills or something that you're looking for specifically before you enter the room?
Absolutely. There's two big things that I'm hoping to get, and two things to focus on. The first, communication. It's so fundamental. I can't tell you how many times I get a page where it just says condition change or second opinion, and that is so ambiguous. I It takes time for me to dig through the chart and try to suss out what's going on. And in the case that it's an urgent emergent situation, I have to know exactly what I need. And that helps me because I then know if I need to get respiratory on board, or I'll just call the provider straight away and say, hey, can you meet me at the bedside? But even in the sense of a patient that you detect a decline, it helps me a lot just to have some sense of what's going on. I really encourage you to use that S bar. It really does sum everything up nicely and gives me a picture so I know what to expect and what I'm walking into. So communication, absolutely paramount. The second thing is get an assessment in. A lot of times I have people in the room and I'll get a page and just say condition change, or they just don't look like they're breathing right, or they're breathing fast. And I say, what's their respiratory rate? And I get it that people sort of get a deer in the headlights sort of feeling when something feels urgent. It's sort of a panic that sits in. So, what I would encourage you is one, absolutely try to get an assessment in, but come up with your own linear way of assessing. We've all heard of the ABCs, it's a very deliberate airway, breathing, circulation. And that teaches you a motor memory of sorts. Like if you approach every patient in the same deliberate linear way, you're not going to miss anything, and it becomes part of your motor memory, so that in an urgent situation you're not missing anything. I expand on it. I was taught this great acronym when I was in nursing school. It's called VOMIT. So I'm first and foremost, I'm getting the vital signs. I'm looking at their oxygen needs. You know, do they have an airway? How are they breathing? What's their SpO2? What kind of oxygen supplementation do I need? Get the M is get them on the monitor. If the heart rate is outside of sinus rhythm, okay, get an EKG. Let's look at exactly what's going on with their heart rate. The I is IV access. You may not have IV access, but at least check. If you think you have an IV, be flushing it and let me know, because if I need to get IV access really quick, we can do that. But it's always nice to know that we have it. T is treatment. You are your patient's advocate. That's part of the S bar, the R in recommendation. You should be having an idea of your mind what your patient needs, especially in the event that you feel that this is becoming emergent. Get that crash cart. Don't wait for me to get to bedside and say, get a crash cart, get the pads on them. You should be thinking several steps ahead. In the event that you think that their oxygenation is changing, get a non-rebreather, get respiratory down there. And then finally, the S is sugar. You'll see me every time I get a page, get a sugar. It's just one of those fundamental things that gets missed a lot, especially when it comes to altered mental status. So again, it's just figuring out your own way to approach a patient in a deliberate and focused way. And the more you practice it, the less likely you are to miss something when a patient is crumping and you need to get your bases covered. So yeah, I would say work on your communication and work on your assessment. That helps rapid the most.
Well, thank you for all of this, Liz. That's very helpful. A lot of good, valuable information in there. I remember being a CVIC nurse last 20 plus years. It's the same information. It's like you've got to know the basics. If you know the basics and you're looking for one specific thing, you got to communicate that to the rapid nurse so they can be most efficient. And that was great. I love the motor memory part too. I thought that was very helpful. Always do your ABCs and your little acronym for vomits. All that would be very helpful as a bedside nurse. So, Erin, I think you're going to talk to us a little bit about how they should contact you and how the primary nurse can help and assist the rapid nurse once he or she arrives to the bedside.
Yes, so the best way to reach Rapid is via telemedic. Now, one of the big complaints that I receive from nurses is that on the portable phone, the telemedic app is very fiddly. If you're on the iPhone version, you're having to deal with these rolling menus that are highly sensitive. And in a high-stressed situation, a lot of nurses are afraid that they're going to accidentally input the wrong information using this. So what I tell nurses is that the best way to use telemedic, especially in situations like that where you got a lot going on, is to use the desktop app for telemedic. It's on every desktop. You can use it on the bedside computer. It's a lot easier to use. You can see all the screens, and they're just drop-down menus, so it's a lot more easy to use in getting all that information in there. If you have a minute and you're just paging out for like a second opinion or a condition change, there is a field where you can put more detailed information. You don't have to put everything, but just a few notes about what's going on, what specifically is the condition that's changed, can really help us to figure out what we might need. If we need to loop respiratory in, or actually respiratory gets the message themselves, so it lets them know if they need to bring anything when they're coming to the rapid. So it can really help facilitate things if you just type in a few notes, especially if you're using the desktop app in order to contact us. If the patient's really crumping fast and you're not able to stand at the computer and type in that alert, utilize your team, your charge nurse, your unit secretary. They too can page out rapid responses, and so they can be doing that while you're seeing to the patient. Um, there are other ways to reach us. Some nurses will look us up on telemedic specifically and then just send a direct message like they would to the doctor. This method is not so effective because when an actual rapid response is paged, it provides a different alert than just a regular non-urgent message. So if I'm in a room caring for a patient, or if I'm working on an IV or something like that, if I get a non-urgent message, I'm not going to be reaching for my phone. I'm going to be focusing on the patient that's in front of me, and I will get to the non-urgent message when I'm done. If a rapid alert goes off, I'm going to be looking, I'm going to be trying to figure out if I need to triage, if I need to utilize my resources, pulling in new nursing supervisor, trying to figure out which patient I need to see first, which one's the more emergent case. So it's just better if you need the rapid response nurse urgently to just page it out as a rapid. It's better for you to page it out and it turned out to be not much of anything than not page it out and there's a delay in care and the patient's status actively becomes worse because we did not get the message as quickly as we could. Some nurses, because they don't like paging at all, will try calling the unit looking for me, because if I'm not actively doing something else in the hospital, might be on the unit. The problem with that is, myself and the other rapid nurses, we are all over the hospital. We go where needed. So as an example, had a nurse that needed an IV access. The patient's blood pressures were a little soft. She did not want to page it, a little bit of stage fright, she did not feel that it was urgent at that time, urgent enough to page out a rapid. And so she called and left a message on the unit for me. Problem was, I was down in the ED helping down there, and I didn't return to that unit for a couple of hours because the ED was really hopping that day. As a result, by the time I received the message and arrived at the patient's bedside, the patient's blood pressures were even more soft. We were having to look at fluid boluses and that sort of thing. So it just ultimately was a bit of a delay in care. So telemedic is far and away the best way to get in touch with us, and just utilize that app, utilize the desktop app. As far as once the rapid has been paged, the way the nurse can best assist, the single best way that the nurse can assist is to stay at the bedside. Now, I understand that out on the floor, you've got 3, 4, sometimes 5 patients. A lot's going on with every single patient, but once you page that rapid, that nurse or that patient should be your top priority. So stay with them, utilize your team, utilize your charge nurse. If you've got other things going on with your patients, delegate those responsibilities to other nurses so that you can focus on this patient. For example, if it's a hot stroke, you're going to have to going with us to CT anyway. So just start making those preparations to be available and utilize others in order to make sure that you don't fall too behind on your other patients. While you're waiting for us to arrive, as Liz mentioned, you can be utilizing that time effectively. You can provide immediate interventions such as oxygen, utilizing the vomit system that that Liz mentioned, or even just seeing to the ABCs, throwing on some oxygen if their SATs aren't as high as we would like, checking another set of vital signs, and then also be prepared with pertinent information to the situation, past medical history, any medications they might have received that might be affecting their status, check that blood sugar. These are all things that you can be doing while you wait for us to arrive at the bedside. As an example, I got a rapid response call for a second opinion, no additional information, and the nurse was not at bedside. She had left to, I don't even know what she had left to do, to be perfectly honest, but the nurse was not at bedside. The only information I could get was that the patient had a change in mental status, but this was a patient with end-stage dementia, with Parkinson's. They were already neurologically impaired, so it was very difficult for me to determine what specifically was wrong with that patient that the nurse felt prompted to call. It was a delay in care that while I was having to dig through the chart to figure out what their assessment findings were and what specifically had changed. Alternatively, recently I got a page for a patient with stroke-like symptoms. That nurse was at the bedside. She had pretty much memorized the patient's chart, and was able to provide very quick information as far as what the patient's last known well was, what past medical history was. They had a blood sugar that was done and ready, and that patient wound up being a hot stroke call, and it really just helped speed things along in getting that patient to CT. She even had the transport monitor on the bedside ready to go, so we were able to just head out that door and get the CTs, get to CT.
That's awesome.
Yes,
I don't think you see that sometimes, do you?
I don't, but it was really great. Just kudos to this nurse because she was just on the ball thinking about it. So those are really the best ways that the nurse can assist. Be available, be ready to communicate with that SBAR, and provide immediate interventions while we arrive.
So I think what I've heard from both you guys is that one of the key things with nurses needing a rapid is that they communicate clearly what it is that's going on with the patient so that you don't come in there and have to dig around and delay, like you said, delay that care for that patient. So communicate clearly what they need. Think a little ahead if they can, like one step ahead, a critical thinker trying to think, okay, I suspect my patient might be going through or having a STEMI, so maybe I should get the EKG machine at the bedside. I think, those are the kind of things that probably trip up some of the nurses. They aren't prepared for this stuff. So then you get up there and you're yelling, where's this? Where's that? Where's this? And so if nurses can critically think ahead and get those supplies or items, like you said, that nurse who was prepared to go to CT and she had the transport machine up there and everything was ready, that's a smooth day. So I appreciate everything you guys offered to this podcast to help the nurses learn the few things about communicating clearly what they need, critically thinking ahead of time, do their assessment skills so they can tell you what they need or what's changed, be clear about that. And that will all expedite for the patient. The patient's what we all are here for. Do you guys have any other comments as we close this podcast?
No, it pretty much sums it up. Just keep up the amazing work.
Yep. And same for you, Liz?
Sounds good.
Awesome. Well, thank you guys very much. And we appreciate your time.
You're welcome. Bye.
Bye. Thank you.